welcome Alison Marshall, who's a professor at the University of Cumbria today. Alison's come to give our third talk of the year in our seminar series entitled Innovation and Barriers to Technology Adoption in Healthcare and the Implications for Scientists and Engineers. So without further ado, Alison.
Thank you. Hi. Right, so I think this might be quite different from some of your areas of research, so I'll try and give a bit of introduction. My background is actually, I started off as a scientist, and I suppose I became some kind of an engineer, so I did physics originally, that's my original discipline, and then I went into software and electronics product development, but as a project manager really, not as a techie. And I became more interested in why people use technology and why they don't use it, and how you can design it better and how you can do other things apart from after the design to improve why people engage with it. So I moved into sort of other areas. I taught product design for a while in Leeds, which linked me into that, teaching students to do user design process. And I now do work at the University of Cumbria. I'm working actually in the Faculty of Health. Actually, we're not a Faculty of Health anymore because we've changed the structure, but it's a part of the university that's in health and allied health professions. So we don't, as a university, we don't teach medicine, but we teach nursing, allied health professions, so physiotherapists, radiographers, occupational therapists, and a number of others that I can't remember. So I thought it was a really interesting opportunity to work with those people and see how technology could work to improve their fields and their practice. And so now I do quite a lot of projects in conjunction with NHS partners and with some companies and other types of organisations. So that's my background. I'm just going to do a bit of scoping of what I mean, where my area is and where it sort of starts and finishes. So a little bit about my centre that I'm director of the Cumbrian Centre for Health Technologies, CASHE. We're very much, we're not really research in the sort of sense of research in this university. We're very much applied research and consultancy studies. So we work, we do contract research, we do, and we then try and develop that into research rather than probably where you're coming from is the other way around. So we are interested in the areas of technology adoption, the innovation process within health particularly, but actually I'm starting to have conversations outside of health as well, and stakeholder engagement in that process. So not just in the design process, but in the whole process from design to adoption, so the trials, the evaluations, the pilots, etc. And we've had various funders over the last, this is sort of over about 3 years really, well 4 years I've been at Cumbria, but really the funding has started over about 2.5, 3 years. And recently we've also started a course, because what we found was that one of the barriers to adoption, I would say, is that most people who are attracted into the caring professions are distinctly unattracted to technology. So we thought actually there's a need for some education and working with them to help them to innovate in their own areas. So we've just recently started a postgraduate course which we've had external funding from Health Education England and the North West Coast Academic Health Science Network. So there's a couple of websites there which you can have a look at. And the scope, the technical scope, the definitions in this area are the terminology and the definitions are very imprecise and variable, so I find it useful to just define what I mean. So I'm interested in the use of digital technology in health and social care. So that encompasses telemedicine, telehealth, telecare and e-health. And the way people use those terms is not consistent. So these are my definitions. So telemedicine means the use of video usually, but actually I suppose you could really include phone as well if you really wanted to, but usually video to enable remote consultations between a professional and a patient. And then people also talk about telecoaching, tele-rehab, teleconsultations and everything. But it's basically where there's a patient and a professional involved. Telecare and assistive technologies is what people use in social care, and this is more advanced, and it's interesting why, because I think social care and social services have a different culture and different, they don't have this entrenched evidence-based medicine. Not to say they don't use evidence, but they don't interpret it in the same way, and they have different sort of culture, really professional. They're not so strongly driven by the professional identities, but more by the organisation. So there's lots of technology there, which I'm sure you're familiar with, for uses in the home. Telehealth is, in my definitions, is to monitor patients remotely. So to look at what's the typo? That should be mHealth. I think that was also correct. So it's to remotely monitor symptoms for people with long-term conditions usually, and enable people to monitor their health at home. That's quite disruptive because it changes how people care for themselves, as does telecare to some extent. And e-health is about the records and the IT underpinning that, and tends to include more also consumer health, so mobile apps and things that people can get themselves. So that's my definitions. And then there's emerging technologies, which I'm, just from the discussions I've had here over lunches, I think there's a lot of work here that sounds really interesting: the wearables, Internet of Things, novel sensors, etc. So I'm quite interested in linking this in with emerging technologies as well. So then I've got a little bit about the environment for innovation healthcare, which you probably will sort of resonate with everyone and you'll understand. But essentially, when you're talking about digital health in digital technology into health, we're really bringing in consumer technology that we all use in our day-to-day life without thinking. When we book a holiday or do our online banking, or as I did this morning, use Google Maps to find my way from the station to this building. And so that's the driver, and alongside that there's I suppose, more negative drivers that we actually just haven't got the money to do it the way we've done it in the past. But it means a change to the clinician and patient relationship. I'm sure you've come across that. And it means a disruption to how people access the healthcare system, which I think is actually disrupted enough as it is, without making it worse. And it also has a crossover into lifestyle and well-being management, which means it's not really clear whose responsibility it is. And then we've got things that people can just go and buy themselves off the shelf. We've got the growing consumer health technology available, which is further complicating it. So that's the sort of backdrop of what we're looking at. And then we know, it was identified 5 years ago, that the NHS is really bad at innovating and adopting technology, and that was identified in this really major white paper, which followed on that. The academic health science networks were then set up on one or two other things. So there's an understanding that it's not good. It doesn't work well. We've got really good technology, but we can't get it into the mainstream. And actually, some of these technologies are not rocket science. They're things that literally we use all the time. So there's something really badly wrong with the adoption process. So why is the problem? And this is what I think is sort of unpicking where the problem is. So we've got evidence-based medicine, which is a good thing. Obviously, we don't want to use new technologies and new processes that haven't got robust evidence. But this has been developed really for drug development and for very sort of risky and quite invasive medical devices. So it's designed so that there's a really clear waterfall sort of process development product development process, that means we develop something, we pilot it, we evaluate it, and then we decide. But in fact, what's happening is we do a lot of piloting, and people write lots of nice evaluation reports and nice papers get published, but it sort of goes round and round, and then we do another pilot, and then it's changed a bit and pilot somewhere else. So there's something wrong with that. In this field, it's not generally wrong, because I think that's the right way to do it for some things, and you go gradually ramp up into different types of trials, and you go to RCTs and so on. But in this field, that's not really working. And why is that? Because actually what the NICE, this is taken off the NICE website, is that the criteria we use are the right ones. We look at whether it works and whether it's going to cost. We look at cost. And it should work. So in telehealth, this was a telehealth pilot. I don't know if anybody knows about the whole systems demonstrator, but it was a huge, big project. It cost, I don't know how much it cost actually, and somebody told me the evaluation cost 25 million. So it must have, but I'm not sure if that's true. It was got quite good authority, but I just somehow can't believe it. So it was a very big project. They had 6,000 patients across 3 different sites in Newham, Kent and Scotland, I think. And they were looking at using the same piece of kit and doing a rigorous randomised trial, and the results they got, there's lots and lots of papers been written, but there's no conclusive evidence, and it has not led to adoption. And that was a huge example of doing it in the standard way. So why does it work? And these are some of the reasons, I think, and I'll come on to more later on. But one reason is that, in fact, they're not replacing like for like. They're changing the way a service is delivered. There may very often be more than one professional group involved. So you might have nurses and physios, or perhaps the ambulance service or something like that. You might have people actually who work for different organisations delivering this service, so it doesn't work. And there's often not even one that's mainly delivering it. It's really crosses across. And then you've got the fact that, in fact, the patient themselves may be part of, they may be part of the how it's delivered. So if they're if it's monitoring, then they may be required to do something, and also they may be using, well, it's in their home, it's part of their home. They're at least giving it, shelf space. They might even be giving it. They might be paying for the line and So some elements of the solution actually are completely outside of the control of the NHS. So that's very difficult, really. We're not well organised for that. And to be honest, the threat of change is much greater to the health provider, and that's kind of the elephant in the room that people don't always recognise. It is disruptive, but the evidence I've found is that even older patients, older people, whether patients or not, older carers, they recognise it's disruptive, but they can see the benefit, and they will work at trying to. They'll learn to use the technology if they need to, or in fact, some cases they don't even really need to, because they haven't learnt the old way. It's because this is the first time they've been in that situation. So it's not the patients that are the problem; it's the staff. Right, so there's a number of theoretical models which I won't go into too much, because I want to talk about my work, but the slides will be there. So I looked at these to look at what approaches have been done, and the very simple one actually, which is the technology acceptance model, is it's a very simple model and it's kind of obvious, but it's really important, I think. So people will use technology if they see it as perceived usefulness and perceived ease of use. The word perceived is quite important, and that's sort of design principle. And then there's something called normalisation process theory, which was the one of these people, Tracy Finch, is actually here in this university, or she was, so this is her, and Carl May developed this model. And this model is quite useful because it looks at the different stakeholders, and that was very useful to me in developing my ideas. And then the other person, this is not very easy to see, but the other work that's very relevant is Tricia Greenhouse. She's done a lot of work looking at problems within the health system itself. In fact, I think, it's mainly the health system, but I think she applies it to public services more generally. And there are some health-specific factors which I think are pertinent. I mentioned that there's a difference between health and social care, and I think some of these are relevant to that. So one of the factors in healthcare is that you have this culture of intellectual free thinking. So it's kind of an academic-based, profession-based process to decide how to change, how to implement change. So you'll have people being guided by their professional associations and the evidence that they see from their peers, and perhaps even having more identification with their professional bodies than they do with the organisation they work for. And the only other type of organisation that I think we see that in is universities. I think it's quite a similar culture where people are identify more with their discipline than with the organisation, and they'll make a decision about the value of something based on external factors very much. But alongside that, we've also got very, very risk averse, which is again the right thing, but it's not. But it's relevant again. And so Greenhouse talks about this concept of trialability as well. So that's another thing we can't always. The trialability in some of these types of innovations is really difficult, because you're trying to do something which is very, very incremental actually in terms of outcomes. So if you're improving how someone manages a long-term condition, you're not going to see evidence that you can measure very easily, and you're not going to see large sample sizes of evidence. So all your evidence is very small sample size, and it's very qualitative, and it's very hard to correlate the evidence with the interventions. So and the only way actually you could really do it is if you had, there's a whole system of demonstrators and attempts to it, but you can't really do a trial because we can't take the whole population and put them in a lab. So trialability is one of the issues, and that's something that I actually talk to managers about quite a lot, where they say, well, what do you do in evaluation? I want you to show this. And I said, well, let's talk about how I'm going to show that and how we're going to get that evidence. And it takes a little bit of negotiation to realise that they need to think what they're going to, that they need to understand what's possible for them to decide how they're going to make decisions. There's the stakeholder complexity, which we've talked about, and then of course there's all sorts of problems in the NHS which are going on, which people are having a lot of feel under threat. So that's also an issue. And there's this concept of system readiness for innovation, and it's just not a system very, very at ease with innovation. And then finally, the other theory is the values-based approach, and there's this concept of dissensus. So there will be different values. So the benefits of implementing something to a manager are not going to be the same as the benefits to the patient, not going to be the same as the benefits to the staff, or perhaps to that person's family, or etc. So there may be conflicts which are often emerge as blockages to innovation. So our model is called the Stakeholder Empowered Adoption Model, and it's really a kind of pragmatic version of normalisation process theory, if anything, because we use the same stakeholders, plus we've added the technology provider, the supplier, or the innovator. and we look at how those stakeholders interact with each other and interact with the innovation. And we've developed a process to negotiate with those stakeholders on what they want to see as evidence and how we're going to get it, and often involving them in an evaluation process. So the boxes sort of describe how the interactions are between those different stakeholders, and the box in the middle, high quality clinical outcomes with great convenience and efficiency, is the shared goal, but then there are all sorts of partially shared things going on which need to be taken into account. And some of the emerging themes which affect digital technology. One of the reasons that health professionals are quite resistant, and I would describe this as a conflict, so these are all conflicts, are because they're concerned that if a patient is more empowered and they have more data that they take and they gather and they can look at and understand, they may become a bit hypochondriac. And this is, I've heard, especially GPs say this sort of thing a lot. And I'm sure that could happen. I'm sure it might do, but it doesn't seem to me it's a reason not to do it personally. But so that's one of the issues. And I think that one we talked about. The other one is quite fair enough, is that actually a lot of these companies design really, really clever systems that can get lots and lots of data and produce lots and lots of dashboards and things and analytical results and alerts. But in fact, they produce a lot of data and nobody has a job where they've got to look at it. There isn't anywhere that can go, which is, it often goes to the GP, so that's another reason GPs don't like some of these technologies. And then there's a trust issue as well with any automated analysis. And then finally, this is more of a sort of design issue. The mode of use can modify the solution, so it might end up being changed and can reconfigured in the way that the designer hadn't envisaged, which can be positive or negative, but it's a very new way of working for all of us. That is happening in the digital age. So moving on to what we're doing in Cumbria. So we've done 4 technology adoption case studies over the last couple of years, and we're working on publishing them. So the first one is published. The second one will hopefully be published very soon. We're at the stage where we've just sent back the second lot of comments and we hate it. So hopefully they won't send them back again. That's dangerous, stick in the sight of it. And then the other 2 are not yet written up, but we're working on papers for both of them. So the first one is with some work done in Blackpool with Veronica Southern, who's the speech and language therapist who developed a procedure and a process to remotely assess patients in nursing homes, to remotely assess dysphagia, which is swallowing problems. So rather than getting in the car and going out to them, they can do it online over video. And what was happening is people were not getting seen in time, so they were ending up having to go to A&E and problems and distress and extra work for the nursing home. So, but in fact, technology works reasonably well, not perfectly, which is one of the problems, but the other colleagues, Veronica's other colleagues, were quite negative about it and quite resistant to trying it, so they've had a lot of problems. Renal telemedicine is using video with patients into their home who are on home dialysis. Again, actually the same technology. This is at the Royal Preston Hospital, and this is to reduce the need for specialists, very expensive, very specialist, very hard to recruit renal nurses going and spending a morning or an afternoon sitting in someone's home just in case there's a problem, because it's very high. These are very seriously ill people, but if they could do home dialysis, then it's great for them and it's great for cost savings. And then the third one is actually a bit different than the other three. This is about a portal, a software portal to enable people to manage their health and report their own symptoms, so that a specialist nurse can check that there's no problem rather than needing to come to hospital, so it reduces outpatient visits. And then the third one is actually done with Professor Steve Robson, who's in Newcastle, at Newcastle NUTH, Newcastle Teaching Hospital, and it's to look at doing consultations for ultrasound consultations in Whitehaven General Hospital, West Cumberland Hospital, West Cumberland Hospital in Whitehaven, and this is to avoid women having to travel from Whitehaven to Newcastle, so they can have an ultrasound done. Well, the sonographer's in Whitehaven and he's in Newcastle looking in on it. So that one's has been quite difficult to implement, although it's a great idea. So, drawing conclusions across all of those, and I'm going to, I can maybe answer questions about specifics, but we've looked at across all of them. And these are some of the enablers and barriers. So the technology exists and the expertise exists within the IT services. And there've been quite a lot of small-scale pilots. So there are people dotted around the IT departments who know how to do all this stuff, got the kit, and they can advise on how to choose what the right supplier or what to use, what's already available. So that exists. But having said that, it sort of works and sort of doesn't. And I think of myself as quite techie, but I kind of saw this from the other side, because we're running this course, and we've had a number of the presentations we've done over Skype. Well, Skype for Business, because we have Skype for Business, which is a paid for proper service. And we have Skype enabled classrooms to do this. And I use it all the time on my own computer, and it's fine. I went into a classroom and it's just a different computer, it's differently set up, and I couldn't get it to work first time, and I was sitting, there was a class full of people there, and so we had to sort of say, right, we'll stop and we'll try again later. And I could understand then, it didn't work straight out of the box. I mean, it's one of those things, if you're sitting in your own office and you can play with it, you can get it working. I do that all the time, but sitting under pressure when you know you're on a time, short time scale. So, and that is one of the things that the digital skills that is just a huge barrier. It's enormous. I mean, I could see it, and I'm very motivated to make it work. But a lot of the nurses and the other professions, they're in a very different approach to me, and it's a huge problem to them if it just doesn't work easily. That's major. And when I first started this, I thought, well, it's ridiculous, it can't be that big a problem, but it is, it's huge. So then there's also huge lack of interoperability and standards and protocols, so that doesn't help. That's why you need the IT people, but really you shouldn't. And then there's a lot of small companies producing these really very good innovations, but they're not, they're not quite there yet. They should have put more resources in them. They don't have the resources to really do that bit of the bit of sort of the commissioning, which the large companies are very good at doing. So they have huge technical sales forces. Small companies don't have that, and so it sort of falters there, just because these sorts of innovations come from smaller companies. So our work is largely qualitative, so we do a lot of interviews and focus groups and workshops, which are kind of action research really, because with the Blackpool study, for instance, we did 2 focus groups at the beginning and the end with the very resistant staff and actually influence their change process to some extent. And these are just some quotes. So one of the things that that comes up is this professional preference. Is people are not trained to work in that way. And in this case, in this particular one, and actually in the fetal telemedicine example as well, between Newcastle and Whitehaven, there's the expert at point A and another person, maybe less expert or with different expertise at point B with the patient, and they're not trained, neither of those professionals are trained to work like that. They're trained to work directly with the patient, and they find that really quite hard. With the Blackpool example, they had a nurse with the patient in the nursing home who would do something to their throat to check swallowing, and so they've got to direct that person, they've got to work with them. That they're just not used to it. It's really hard. So they need actually to have that kind of training. One of the sonographers in Whitehaven said that it made her feel like she was incompetent, because sonographers are used to just being in control. It's just them in a room with the patient. And then there's some positives. Actually, the renal nurses were much more positive, but the renal nurses are quite techy because they've got to get dialysis machines working. So they were much more positive. So, I mean, you just have to allow a lot of time, and think about how much time you think it might be, and it's probably 10 times that. But then there's also issues about changing job role, and that's in an atmosphere of change and change being imposed on people. So again, that needs to be worked through, and that innovations need to be seen as a change management process, not just a technical process. And there are situations where negative perceptions can have delayed or blocked good telemedicine interventions. So the sonography example, it was delayed by over a year because of blockers in the system. There were people blocking it, and we've kind of unpicked that by interviewing all the different people. And they were blocking for good reasons, and so the one of the concerns was that the staff resource, so if a patient's referred from Whitehaven to Newcastle, then they go under their own steam. There's no resource required in Whitehaven. If they have to do a joint consultation, then there is resource. So there are all sorts of reasons like that. But people block in ways that are not immediately obvious, and they emerged over time. So there's some all sorts of different ways that negativity can block good intervention, and there's lots of examples of that. That's my favourite graphic of all time, which just put up there. But then there's some really good enablers. So there's some fantastic innovative people. So in all these case studies, there was a kind of champion who was a clinician who saw that there was a vision and that there was a benefit, and absolutely drove it through, got little bits of funding to trial and demonstrate things. And then the other thing which I think is actually a really nice thing is all these negative, obstructive people. In fact, when they understand that this is benefiting the patient, in just about all the cases that I've ever had conversations around, that motivates them. So never lose sight of that, because that's why people go and work in these sorts of jobs. And a lot of it is a need for education and training, and we don't train our health professionals to innovate, to learn to use new technology. We don't train them in technical skills. So, okay, moving on to the patient. So the patients, this is a kind of a reason that you often get from the negative side, negative camp. Well, people say, well, the patients won't be able to use it, they're all too old, they don't have the skills, they won't want to learn. In fact, that is not, we've never found that. And one of the interesting things in the Blackpool case was that the patients didn't realise that what they were having this thing called a swallowing assessment. They'd never had one before, and they just assumed that was how it was done. So they didn't think this. They didn't know this is different and new, and it might not be as good. They weren't told that. They didn't need to be told that. So that's something to be borne in mind. You don't. Well, some people might have had them before, but on the whole, when you have a new procedure, it's just new and it's difficult for many reasons. And then there's lots of examples about time saving and convenience. I quite like this one from the Patients Know Best web portal, the patient record system, which is talking about people going on holiday. Because these are people who have, their lives are ruled by their illness. So, and then there's the management, and this is also an area where there's lots of problems. So, the enablers, I think there are quite a lot of enablers now. In the last 2 or 3 years, or very recently, there's much more policy levels and a very high level that things have to change. So there's a lot of top-down influence. But there are huge barriers. So one barrier is the poor quality evidence, and there's lots of bad studies and bad research where people have done trials and they've analysed data, which is there isn't enough to do a quantitative analysis, but they've done one, and all sorts of things like that. And so managers are influenced by that. Cost benefit is not always clear, and there's perverse incentives that affect some of these services. So if you're reducing outpatient appointments, the trust that provides those outpatient appointments might not get paid as much. Ludicrous. So, but I think that will probably change fairly soon, because those people at the top wanted to. And then there's just the avoidance of conflict internally, because you've got all these people blocking each other and not getting on. So it's easier just to not do it. And there's a distrust of the suppliers, because they're often small companies with no track record. And then this is sort of where I'm up to. I might just not spend much time on this, because I think we're okay. There's last time for discussion. So this is, I think, where we're at the moment is we have a conventional process for the waterfall method for product design, where we do a linear, one stage at a time. We develop something, testing, and then implement after that. And we're applying that into technologies and a system for which it's no longer appropriate. And there are other types of more iterative techniques called agile development, which is used in software much more, where it's much more iterative and much more user is involved in the design process, and it's also called co-design or co-production, co-creation, those sorts of things. But it tends to be about the design stage and not about the evaluation and the adoption stages. And I think that's probably where I can see that there could be benefits. So the other idea, this is jumping around a bit, these sort of new ideas that I'm thinking about. You may have seen this sort of description before of different types of people and how innovations are diffused. It's work originally done in the 1960s, I think. It's quite old. And so people have different interests in innovation. So I think I'm probably actually with most things, I'm probably in the early majority. I don't go out and get the latest new gadgets. I wait until I've got various friends who do that, and I let them do it and I see what it looks like, and then I'll probably, a few months later I might try them. But I'm definitely not a late majority. So people fit into different categories in their attitudes to innovations. And then there's this piece of work which was done. I've missed the reference off there. But this was work done by Geoffrey Moore. There's a book called Crossing the Chasm, which was written in the early 90s. And he talks about a chasm between early adopters and early majority. And I think that's where we are with digital technology, because we're talking to the techies and the early adopters, we're not talking to the early majority who have different ways of making decisions. And so in order to do that, we've got to look at how we do that, how we work with them, and how we work with their decision-making processes, and help them to understand what kind of evidence they're going to use to make decisions and what is possible to get. So there's something about the evaluation, something also about the readiness for change, and a lot of this is I think an educational thing. So how can we educate people at at undergraduate level so that they're more absorptive to change. I'm also interested in working with companies so that they're better at doing this process, and because I have quite a number of companies who say, well, can you do an evaluation and write a paper for us, and then I tell them how much it'll cost, and because to do a proper rigorous evaluation, it's got a cost, and they're companies who are maybe spending something like £50,000 to £80,000 on their developing of their products, because these are agile software products which can be brought in quite quickly. They're not going to want to spend even 10 or 20,000 on an evaluation. So they need to work out how they do that and understand that themselves, rather than all as if we've got to do it differently. So there's something about working with companies, and then we also do work with policymakers. So quite a lot of all the health economies at the moment are all writing these things called local digital roadmaps for NHS England. There's quite a lot of thinking about that going on, and trying to work out how they can do that and how they fund. So I think a lot of the problems are caused by the funding processes. So you get external bodies funding some slightly maverick clinician who doesn't get on with their management and hasn't got the support of all their colleagues, but they get an external pot of money, and actually it sometimes doesn't really solve the problem. So the funding isn't always appropriate for the innovation process either. And that's the end of my slides.